Moving forward now, I'm going to take you through 3 views on gait analysis, what I would do for those different views and how I would assess them. So the first view that we're going to look at is a posterior view for gait analysis. And as you may know, this is the common view that we all look at as practitioners if we're doing a gait analysis. The first thing I'm going to do, however, is break down some baseline anatomy and help make sure that you guys are familiar with the structures that are important to look at when looking from a posterior angle in someone's gait. I've just got a model of the foot here, and to break it down, we're going to remember that the ankle mortise here, so tib, fib and talus, is sagittal plane dominant, meaning that the axis of movement means that the ankle will mainly plantarflex and dorsiflex. Underneath that, we have here the talus and the calcaneus, and that forms what we know as the subtalar joint. And this one's planal dominance here is eversion and inversion and abduction and adduction. So looking at the coronal and transverse plane. A key thing that you guys need to remember at home is that when the foot has hit the ground and the distal aspect of the foot is now made in contact and is fixed, it is now a closed chain movement. So all your abduction and adduction goes away. So the calcaneus mainly moves in its coronal plane, eversion, inversion. A super important theoretical point to make sure you remember. So when you're looking at gait, you can really harp in and focus on the calc as your key focus point. So in terms of what I look for in the posterior view, there are 3 things. And not only in the posterior view, I'm going to break it down into simple 3 things for the side-on view and for the front-on view as well. So you guys at home can make sure it's quick, simple and easy to digest, and then implement, which is the most important thing that I'm after. So the first and most important thing that I look for then, based on what I've just spoken about, is the heel contact point from a posterior view looking at gait analysis. Your heel contact point is going to really determine whether the patient has the ability to pronate or not. Now, if they land in an inverted heel position or calcaneal position, you know that the patient has room to move to pronate. If they land in an everted position, you know that there's less room. So it is incredibly important to understand that if they are landing everted, the talus on top will plantarflex and invert over the calcaneus to make up for the lack of movement of the calcaneus in the other 2 planes of movement. That's sometimes why you might see a person with a flat foot have a big navicular bulge. It's because when the calc is everted, that talus is actually plantarflexing and inverting over the calcaneus. So key thing to look at is at the heel contact point, are they everted, are they inverted, or where do they lie in between? And if they're everted, that's got to be one of the key points you look at addressing straight away to make sure that patient has room to pronate. Point number 2 is whether the patient's foot is abducted or adducted during gait. I guess the easy way for you guys to look at this when you're assessing a patient is if they're abducted, you can see more than 2.5 toes when they're walking, and if they're adducted, you can see the big toe pointing in. This is a key criteria for you guys to look at because at the end of the day, the further abducted they are, the more center of mass is going through the inside of their leg. And that means the more pressure and rate of pronation that's going to occur through the foot, the ankle, and tibial torsion through the knee. The final point that's incredibly important to look at from a posterior gait analysis is the rate of pronation. The rate of pronation or the torque occurring around the subtalar joint is something that's not easily been able to see by eye, but using applications such as coach's eye or huddle technique, for instance, are really important tools that you may be able to use whilst in the clinic to be able to see how quickly someone moves from a heel contact position into a mid-stance position. This speed is incredibly vital for you to know the stresses that are put on the muscles that help decelerate pronation. And one of the key muscles for that is the soleus muscle, hence one of the causes for medial tibial stress syndrome. So look at the rate at which someone goes from heel contact to mid-stance, because that rate is going to be a key determinant in how they're absorbing shock and then how they recoil that shock back into their propulsion.